happy to take.
There's another question over here.
Yeah, I'll just say that in medical school 20 years ago, we did our first IVs on each other. So this is a great improvement from a guy who had a huge bruise for days, I can tell you. But my question is for Dr. Provost, and certainly Dr. Slavin or Pomeroy have comments on this. I'd appreciate hearing them. One of the things you mentioned, Peter, was you have to have buy-in on the science of what you're doing. Julie talked a bit about the leadership component at the top, but how difficult was it? How long did it take for people to actually buy into, as clinicians, your other intensivist colleagues, that this was valid science, with valid outcomes and valid process measures before you could get them to do that? And how much of a barrier is this in general to implementing new scientific approaches to how we improve care?
Yeah, thank you, Atul. That's a great question. And I'd ask you to think about developing these programs similar to drug development. So for example, we would never think of giving someone a new cancer drug without studying it first in phase 1, 2, and 3 studies and then having some approval, right? It would be too risky. And yet, we largely approached quality just throwing things out there without adequate science, and it's key. And I think about these literally in 3 phases. So phase 1, like phase 1 of drug development, is gaining agreement on the evidence and the measures. And sometimes the measures don't exist and we have to develop them, or I think if the science isn't good, it could inform NIH or others' research agenda to say, hey, there's a real gap here. Phase 2 would be to pilot test it, and you heard that same plan that Julie said. And then phase 3, when you get the kinks out, you can roll it out broadly. And when we first started doing ours, there was a lot of resistance to Atul, in part because nobody believed it was possible. And that was really the resistance is, you know, Peter, we're at Johns Hopkins, we take care of sick patients, stuff happens. And so the way we countered that argument was to say, okay, let's just see if we can make sure 100% of patients get the checklist. First, do you agree that we ought to be doing these items on the checklist? And luckily, there has been research in this area, so the science is quite mature that we could be guided by science. So our clinicians said, okay, we agree we ought to be doing this. Let's just see how often we do it. And we started, I was doing those things 30% of the time. You know, and that's kind of the inertia state for most evidence-based practice that we've seen in this country. With then applying some human factors tools and other culture change, we got up to 100%. But what we framed it was, we said, rather than argue about how low these infections can go, let's just start with making sure everybody gets the evidence and see how low they go. And if they don't go down, you're right, the patients are sick. Well, what we saw was that we nearly eliminated them, especially when we started then digging into the few remaining infections and found out why and brought to bear science. And I think that really galvanized not just our clinicians, but in many sense, the broader healthcare community to say, when you bring science to this, I'll buy it. And I think many clinicians have pushed back against quality, in part because the science wasn't good. I mean, the measurement was poor, the evidence wasn't there. We asked them to do things that often didn't make sense to them as clinicians, to me as a clinician. I think now with this effort is we're saying, okay, yes, we're going to be accountable for that, but we want to make sure that the science is good because it won't work any other way.
Yes, question in the back.
Hi, so thank you for being here. I just had a quick question because, of course, access has sort of been left out a little bit of the conversation. And so I'm thinking about academic institutions that are obviously like more consistently funded. But what are those institutions doing to then take these practices, these best practices, to, I guess, to address the quality disparities that exist in smaller institutions that are not like well-funded academic institutions, such as smaller clinics in rural areas or already underfunded areas that don't have access to major institutions like the ones listed.
Yeah. You know, that's a great question, but we actually hope that the vector for actually the dissemination of a lot of this is going to be through graduates, through residents that actually go into private practice, instead of just adopting the practices that currently exist in those communities. They bring their experience to help improve and change those practices. You know, that's actually a very powerful force in terms of how we deliver care. And so that's part of what we're going to try to teach both students and residents in their training is not only how to do the right thing at the right time, but how to really articulate how important it is in an environment that actually hasn't seen it before. One would hope too, if we become pretty successful in this, that we could disseminate it through many other institutions. But Dr. Slavin can probably address it, being involved with Partners, which actually has a significant Boston market share with many non-academic institutions.
So I guess I'd say a couple of things in response to your question. First of all, academic medical centers in this country already take care of a disproportionate share of the underserved in this country. We make up 6% of the hospitals, care for about 50% of the uninsured in this country. So if we're focused on these issues, people with trouble accessing the healthcare system are going to be better served. Secondly, I would argue that in this day and age, we need to be looking at rural health clinics at other countries in the third world and that have very cleverly figured out ways to deliver better care at lower cost than we have and adopt some of their practices. So this learning that can go on among well-resourced institutions and those with fewer resources can be bi-directional. And in Boston, for example, our colleagues at the Brigham and Women's Hospital are using some techniques that they discovered in Haiti to care for HIV patients and are now applying them routinely in Boston to deliver better care to patients with HIV at lower cost than we had previously thought of. So, as Joanne said, through our teaching mission, we will be training generations of physicians to learn how to do this, and they will practice in institutions throughout this country and throughout the world. And certainly that my hope in the future that the Peter Pronovost, the Atul Gawandes, the Don Berwicks of the world will not be the exceptions, but will be more of the rule in terms of physicians who are capable of not only, we're very committed to delivering outstanding care and have the skills and the tools to make their care ever better. So that is certainly an important part of this initiative.
Could I add one thing to that?
Sure.
Perhaps in the past, academic health systems have been somewhat isolated and you kind of came to them. For us, that's no longer the model of an academic health center because our mission is improving the health of our communities. And so academic health centers have very extensive networks of affiliated institutions, small institutions. And so my own institution, University of California, Davis, is affiliated with many small rural hospitals across Northern California. We're connected by telemedicine. We send our students out there through a program called Prime Rural, and we have then designated those learning centers as rural centers of excellence. And that is how, and their physicians come down to and interact with us continuously, and so that the culture of quality, the approaches to quality, the implementation science is actually done in those places. So think of academic health centers as having this extensive network of connections that really cover broad numbers of communities and patients that we serve.
Yeah, I'll just add, in our national project for bloodstream infections, in most states, it's the academic medical center who's coordinating it. So in Massachusetts, in California, in Maryland, that the local scientists are helping to support. I mean, as Peter said, there's clearly a bi-directional learning, but I think that academic medical centers are really seen as an asset for the community to help ensure best practices are used.
Question? Yeah.
Dr. Pronovost mentioned the statistics in Michigan and across the country for reducing the central bovine infections. Are there benchmarks that all the schools are trying to reach, or broad guidelines that you're trying those schools to attain?
Yeah, first of all, we want them to meet their own benchmark. So continually improve the infection rate at their own institution. Certainly our goal would be 0 infections. And I think it would be disingenuous to not say that that would be the ultimate goal. I think it's going to be challenging at some institutions and less challenging at others. But that's why the UHC collaboration is so important because that comes through learning collaboratives, cohorts of people that decide to work together and figure out what works and what doesn't work at their institutions and really question their own outcomes and their own data instead of just accepting them. Any other questions? Yes.
You talked about the development of outcome measures, and I'm wondering if those measures are going to line up with existing measures in the Medicare program, for instance, with inpatient quality reporting and value-based purchasing. Will they be very similar, or this is a whole new process?
We tried very hard to select measures that didn't have to be reported differently or didn't have to be calculated differently. So, for example, we're using the central line, the CDC central line bloodstream infection rate. We'd be using the compliance with the surgical checklist. So we're actually trying to really use currently public reported data. Any other questions? Well, thank you, everybody. It's a beautiful day, and so at least you have 20 more minutes of your lunch hour to enjoy the wonderful weather. Thank you very much.